in the Western region, part of the faculty downtown in Northwestern, just parachuted here so patients in the western suburbs don't have to go all the way downtown to see a fellowship-trained brain tumor surgeon, okay? And I have two of my colleagues here as brain tumor surgeons, and we often share cases for the obvious brain tumors are complex, and we sometimes need our colleagues to help out. So you might, like I said, meet those people, but I'm the one on call, so I was the one responsible to decide, to bring you over, because I personally do my practice here, not at Delmar, so I take advantage of the resources they have here. And basically, it's my home court. So this is the CT scan I'm going to show you first. Try that again. So this is CT scan. This is your left eye. That's your right. Oh, sorry. This is your right eye. That's your left eye. Okay. We're looking face on, and then we're scrolling backwards. We see, first of all, you have what's called hydrocephalus, which is buildup of fluid in your head. And that's because you have pressure at the back of your brain that's not letting the fluid leave. Okay, so the hydrocephalus is secondary to some type of mass. It's kind of seen here, not that great, but you can see something. I would say something's happening over here with some swelling. So that's why, I'll show you a side view too. This is a side view. See that little, almost looks like a ball there? Okay, there's a mass there. And that's pushing on this thing called your fourth ventricle, or causing stenosis here. So that's not letting this fluid that we all have leave. Okay, so when we do the MRI, we're going to do the same thing first, face on view. There's your right eye, there's your left eye. We see the hydrocephalus, the buildup of fluid, and then we see that thing, which is abnormal. One that's abnormal because it leaks contrast, and then it's weird that it also leaks contrast in different directions. Because in this area, we would have expected not this leakage of contrast like there. We would have expected just more of a round ball, meaning it's not the typical what we would expect for a mass in this area, like a metastasis. Okay, that's what we usually think in anyone with a mass in the cerebellum. That's where this is, cerebellum. We think metastasis. It doesn't look like a metastasis. Okay. Then we think of other types of tumors or cancers, and in the end, what we say is tumors the rumor, tissue's the issue. Until we get tissue, I don't know what this is. And I do a lot of brain tumors, over 250 a year. This is all I do is brain tumors, and the main question is something ain't right. This doesn't look like the typical metastasis. It looks like something that came from the brain, okay? Or something like a lymphoma that travels through the brain. So the issue is we need to get tissue diagnosis, and the issue is we can't let this hydrocephalus stay. We need to divert that fluid temporarily until we figure out what this is or how much we can safely remove. Some diagnoses don't need full resection. Example, like this lymphoma that we described, all you need is a tissue diagnosis. You put people on steroids or the actual treatment for it. Steroids help reduce swelling, but it also makes lymphomas melt away. But once you get on the tumor treatment, chemotherapy, it melts away. You don't need to resect it, meaning the brain just stays there and the tumor's gone. Okay, so the difference in management is very, very different than a cancer where we need to remove as much as safe as possible, like let's say a glioma, a ependymoma, all these other cancers. Yes, we want more of this out. Okay, but the fluid we need to temporize and get that out of your head for a bit so that your headaches improve, but also the head of hydrocephalus improves. So the issue is we don't know what this is. Doing a biopsy is not unreasonable, but that does not change the fact you have the hydrocephalus, and it's a very tight area. And sometimes then we are concerned. We do a little biopsy, it bleeds, we get more swelling, we have more hydrocephalus, the drain we can place, but then we're stuck. So we then have to go back, take out more bone, take out more tissue. So that's why I try to do the first surgery, the best surgery, never surgery again. We go in with the intention to relieve the swelling in the back by just taking off some bone that we do not uncommonly for tumors, opening up the dura, which is not uncommon we do when you want to give space, putting a drain in the head to release the hydrocephalus. Start in the OR with a biopsy, because if it is a lymphoma, like I said, we don't need to resect it. Lymphomas just need treatment to make it go away. And steroids help to make it actually disappear, but if you don't get the tumor treatment, then it'll just come back. So steroids help, but that's what I think we need to do, okay? And the question is, how well were you, meaning I didn't know how well you were and how long we can wait, right? We're concerned about waiting is this hydrocephalus isn't going to go away. And you can see here, this is crowding, this area of the cerebellum is crowding the base of where the skull finishes. You see that? That's not normal. So meaning, you know, the more we wait, the more things can swell, therefore it will clog up this area and the more hydrocephalus. So the question is if we're going to do surgery today or tomorrow, and that's what we're trying to figure out. Okay? The way surgery works is under a general anesthetic. You don't remember or feel anything. We make an incision at the back of the head, okay? Move the skin and muscle aside. Temporary bone removal or removal permanently of the bone here, like I said, to give space, which doesn't affect you at all. Open up the dura, and then either we stick a needle in to get that biopsy, and then in the OR they tell us, hey, this looks like lymphoma. Then we're done with this portion. If they say that we don't know, doctor, this looks ugly, we'll take out as much as safe as possible, okay? It doesn't have a discrete border. See this? This is like jaggedy. That's not typical of like I said, a metastasis. That's not what I'm thinking. I'm thinking it's some type of either glioma, where we try to take as much safe as possible, or lymphoma, where it's just biopsy. Okay? We do as much as safe as possible. Then we suture up the dura. Sometimes we put some bone back. It depends on many different variables. You don't need that bone. Okay? And then in the OR, we also use this MRI as our GPS system to place this drain in that's there temporarily, just to help relieve that fluid. Okay? So that you can, so like that, it's going in. Okay? And it's
Does that stay in there for a while?
temporarily until we feel like it's safe to remove. Usually, when this starts to come down, when we've given more space, when the CSF flow has been reestablished, we can, just remove it at the bedside. Okay. Rarely does hydrocephalus persist that we need to do another surgery to permanently leave a tube in your head, go under the skin into the belly.
Oh, that's rare.
Rare.
Oh.
Okay. And that can happen anytime in your lifetime if you develop hydrocephalus again. Okay. Then we have to wait the final diagnosis to find out what it is. Okay. Okay, guys. So let me figure out in the next few hours